and 2 OEB.
Two
So we're
OEBs.
good to go, right? All right, so let's bring this meeting to order of the OEB Strategies and Evidence Outcome Work Group this fine March 4th, and time is 9 o'clock. As attendance, we have, hold on, going back to my sheet here. So from PEB, I see Greg, Kimberly, and who was the third member? Andrea. Okay, and then from OEB, we have Andrea, Dr. Laura, and myself. So that is enough for us to handle action. And our first action will be to review last month's minutes. Did everybody on the committee get a chance to review the February 4th minutes? And if so, can I have a motion to approve?
This is Andrea. I make a motion to approve the minutes.
All right. Do we have a second?
This is Greg. I can second that.
All right. We have a motion and a second to approve the minutes. All in favor, say aye. Aye. Anybody opposed? Hearing no responses, we will say approved for the minutes. So now we're going to move on to item 2. We're going to review the medical and dental plans, proposals, and recommendations for the upcoming renewal, which is Mercer, and Mercer's going to share, right? There it is. All right. And Dr. Schwang and Christy Ewing are going to present, right? Am I good on that?
Yes.
All right. Way.
Thank you, Bill.
Oh, hold on. I got a hand up.
Sorry,
What?
I just, Bill, just when we get to the point of these recommendations where we need to make actual recommendations to the PEB and OEB board,
Yep.
just to kind of reiterate that underneath the charter, the PEB members will make the recommendation to the PEB board and the OEB members will make the recommendation to the OEB board.
Yeah, that's why I was counting OEB and PEB members separately, so that we
Oh,
would
okay.
have enough on each board to make a recommendation. That's why I needed
Okay.
2 from each board. That's why I was counting that way.
Oh, okay. I just wanted to.
Yeah, that was my purpose, anyways. Okay,
Okay.
let's roll.
Next slide, please. So this section is on the clinical renewal recommendations. And to Bill's point, we are seeking OEB and PEB CL members to make clinical renewal recommendations for each of their respective board. What we have in place is 4 total considerations. 2 will be specific to OEB because PEB already has comparable offering in place, and 2 are requiring both recommendations from OEB and PEB. Next slide. And just to recap, the SEOW charter and the clinical renewal recommendations, the context of this is it requests the following members develop their recommendations towards each of their respective boards regarding benefit program recommendations will be based on a review of clinical outcomes, health equity considerations, and relevance to their respective boards' goals, value, cost, and other factors deemed appropriate by the CL members. While several of the clinical renewal decisions have cost and other considerations, our primary goal of the CL is to make a recommendation through a clinical outcomes-based lens in context of kind of what it will have a positive impact on the broad group of your members and constituents. Okay, so with that in mind, again, to summarize, we have the following, next slide, on the table for this renewal requiring recommendation. The one on the left, the two for OAB, are site of care and fertility support. And that is because already there's a comparable offering on the PEP side. And then the two on the right are both for OAB and PEP to consider, which is menopause support. And then specifically a skin cancer tracking app to promote through the membership. Next slide. So with regards to the first one, this is the site of care, and just a refresher. So this slide was presented in the February meeting, and the proposal via MODA is to augment their current process, a way to sort of review the case and identify opportunities to redirect site of care to a more cost-effective site of care location, basically. So this is a seamless sort of change in the sense that it's already existing process, the utilization management review. So it's seamless for the member and provider in that they don't have to do any additional steps. Is literally what MODA is doing is, while they're doing the utilization management, identifying the site of care opportunity specifically for the targeted procedures of advanced imaging and musculoskeletal procedures, and then making that option available and embedding that in that utilization management process. Special considerations are in place for Eastern Oregon just because of the lack of alternative site of care potentially.
Yourself somehow. You said about Eastern.
Is somebody muting me?
That's a good question because I just got muted myself. Right. Okay. You said about
Okay.
Eastern Oregon and then it muted, right? But
okay, thanks, Bill. Yeah, just let me know if that happens again. So with regards to Eastern Oregon, it is being excluded just because of the geography and the availability of alternative options that are obviously not going to impact the member in a negative way. So they are excluded. But that's the proposal that's been in place. It has been reviewed as a neutral impact by the Health Equity Committee. So that's been sort of looked at. And that is what is before us on the table with regards to site of care. Questions about this quick synopsis of what we went through on February?
sorry, this whole the direction is done in PEB, right? Just to make sure we're clear on that.
Yes.
Greg.
So is there, so for Eastern Oregon, I know we have a lot of members out there. Is there something that is in the future coming, or is this something that will just always be just for the vote?
I can speak to the practical realities of this. So this is just focusing on a site of care alternative. So it's about a provider who's going to do the service, and they can go A or B, and just because of the way billing is set up, B is lower cost. That option may be limited just because of alternative place of services. And in terms of, if that will expand, it's a combination of kind of what the providers are doing in that community, as well as what MODA has in place in terms of relationships and network coverage. But that's sort of a static explanation in terms of sort of future state. I'll leave that for MODA to address.
Is there an appeals process that the member can go through if there's an issue?
So I think this is basically presented as a cost sharing and cost benefit alternative. It's not saying, so the UM takes care of the decision. So obviously they can be an appeal for that, but this is just saying you could have this procedure done here or there. And
one costs more.
Right. Just because of the facility cost.
Okay. So that's out of pocket when you say cost more?
Cost more, yes, at the plan level and
Okay.
then potentially cost sharing, yes.
Dr. Laura?
Good morning. If you can clarify regarding the neutral impact with the Health Equity Committee, please. Thank you.
Hey, Christy, can I pass that to you? The review and the neutral impact determination?
Yes, you can. Hi, Dr. Lara. So our Health Equity Committee did our deeper dive into the site of care. I think our initial reaction was kind of a neutral stance as of recognizing it does provide some financial benefit to the member without really disruption, because this is done, kind of behind the scenes. The member is just, going to a place that is ultimately going to have less out-of-pocket costs for them. The one drawback, obviously, that the group did feel in our discussion was obviously that it is only offered to part of the population. So not being available to Eastern Oregon, obviously that is an equitable consideration, that it's not for the full population. So those were kind of the two components. And we do have kind of our more detailed kind of conversation that we had on some slides that I'm happy to share with you all after today's meeting as well.
Erica, you got a quick comment to chime in on?
Yeah, I just wanted to say this program is available in Eastern Oregon. It can be turned on for Eastern Oregon. In our proposal, we had suggested not including Eastern Oregon just because access is more limited in that part of the state, but it absolutely could be turned on. And I just wanted to clarify, there is an appeal process for this. When this goes through, it goes through with the PA, when the provider submits the PA, and then it'll either get approved or not approved for the site of care in which the provider is requesting. And then if the provider really, feels that, no, this location does need to happen, there is an appeal process for that. And then the other thing I just want to point out, and I know that Mercer had mentioned this last month, I believe, when this was shared, is that if a provider submits a request for a location and it's not one of the lower cost options, if they do not have referring rights to that lower cost option, then the location that they are requesting would be approved. So just a couple facts to point out there.
And Erica, follow-up question regarding the appeal. How long it takes to appeal the entire process? I'm just thinking about continuity of care at the patient. Yeah.
Yeah, and that I don't know it off the top of my head. It is the standard appeal process and timelines. So I can get that information for you. I don't know it off the top of my head.
Thank you.
Mm-hmm.
Dr. Schwang?
I just have a follow-up question, just it may be helpful. Erica, do you have stats in terms of typically the amount of appeals on this? I wouldn't expect it to be many because it's just I can go A or B and either is fine because I'm the provider still.
Right. I agree with you. It's probably not many. I don't have stats on me. I can ask Epicor for some. This is not something that we have on our larger book of business right now. We just implemented it 1/1 for PEB and other parts of our business. So we have personal experience since January. So I can get that information for you, and then I can ask Epicor for their standard number of appeals that they get.
So I got one more clarification question. Maybe Erica can respond to this.
Yeah.
So in this program, without the program, you pay whatever the out-of-pocket share cost is going to be for your plan. With the program, I'm thinking that cost goes down a little bit if you choose the preferred provider. So in Eastern Oregon, the person's going to pay now because it's not offered there. They don't have the opportunity to save if they choose. So what is the downside of not offering it or offering it in Eastern Oregon? Because they're going to pay the regular out-of-pocket plan price because we're not offering this potential.
The way it works is the member really never sees anything. So when the PA gets submitted, it's either approved or not approved. It's not a choice. It's a low-cost facility that the provider's requesting, and so it's approved, or it's not a low-cost facility and it's going to get denied, and then the provider just needs to resubmit with the correct facility. So the way that members pay less is because we're pretty much saying we're not going to allow the higher cost facility, and we're only allowing the lower cost facility. So because the member is going to a lower cost facility, they're paying a lower amount in cost sharing for that service. Yeah. So for
clear. Got it. Okay, so I get the point. So we can revisit this Eastern Oregon question each year as we go along, right? And say
it's available for Eastern Oregon. Yeah.
Right. I mean, there might be more clinics in a year. There might be whatever changes, but it's dynamic, right? So.
Correct.
Okay. All right. I don't see any more hands. So let's. Okay. Site of care. We're going to discuss it now from a OEB point of view, since it's already in PEB. This is Dr. Laura and I. I'm good with this concept. We need to kind of control costs, and we're certainly this year we're in some spending difficulties, so rate difficulties. So I'm good. Dr. Laura, you want to chime in with me on this or be opposed?
No, but I want to make the note that we're going to keep reviewing the Eastern Oregon.
Yes.
For sure. Yep.
And just put that on staff to have that on the work plan.
And if we can compare with data, I know we start in January, but
yeah,
it'd be great. Thank you.
Okay, so other than that, with that note, you're an ad and I'm an ad. Do we agree? Okay. All right. So whoever's noting that, where the OEB side of this question is, we're going to recommend adding this to the OEB offering. Okay. All right. So this is also an OEB thing because already, and this is exactly the same as what PEB is doing. Is that correct here? The facility support. This is what we discussed last month.
At this level of our discussion and decision making, basically the SEOW recommendation is a clinical one. So how it ends up being structured will be sort of at the OEB board and renewal.
Yeah, I'm not talking about cost. I'm talking about like how many rounds are allowed in IVF. Are we matching PEB on this? From obviously the more rounds. This is basically around IVF, right?
It is. So it's the expansion of current coverage to include artificial reproductive technology, including elective and iatrogenic fertility preservation of eggs and sperm.
Yeah, and then what I'm asking is, it's what 50%-ish on the first round. Obviously, more than that on the second round, and I don't know how many rounds. I see Kirsten has her hand up. Sorry.
Hi, Bill. Just to reiterate something that Ian mentioned. At this point, the actual benefit, it depends on what financial impact we can afford to put into the round, into the renewal. And so the actual benefit design will be worked out with the board as we progress through the renewal process. But this is inclusion of artificial reproductive technology, IVF, and some other therapies that we don't currently have included in the OEB benefit. So even if we weren't to change the benefit this year and we were to keep the same lifetime maximums, this is still saying that we would increase the services covered because now we'd be covering ARP.
Okay, right. So now turning my focus over to Dr. Laura, this is a recommendation from SEOW to add IVF to our covered fertility coverage, I should say, covering it. Do you have any questions, Dr. Laura, on this? This is an OEB only decision already in PEB.
No questions.
Yeah, I'm a pro on this. I'm for. Dr. Laura, are you the same?
That's right. Yep.
Okay, so this is an ad for OEB.
Okay, thank you.
Let me ask the PEB members. You got anything that's going right or wrong in your fertility coverage that you want to mention?
Holly, Andrew.
Andrew.
Hey there. See if I can get off camera. Okay, there I am. Hi, everyone. So the PEB board has made decisions over the last 2 or 3 renewal cycles to expand the benefit. The most recent benefit change and expansion that happened as of 1/1/25 was to partner with Kindbody and Progeny. And so given that that's a new change, we don't have a lot of feedback, but those generally are very well respected vendors, and we're optimistic that that's going to play very well. And so that's on the vendor partnership side of the benefit. With regards to the actual benefit design and member out of pocket cost share, that also has expanded over recent years. And so where it stands today is that let's see if I can remember. So with Progeny, it's a smart cycle benefit where it's 1 + 1 smart cycles are covered in a given year. And so you have a full cycle covered. If that is unsuccessful, you can have the +1 second cycle in that same year. Under Kindbody, the benefit is an annual maximum of $25,000 on the medical side and an unlimited pharmacy benefit. And so, fertility benefit expansions can come with a not insignificant price tag. And so by making these changes over the course of several years, we've been able to move in the direction that the PEB board wanted to without doing everything in 1 year. If that makes sense.
Yeah. And from a clinical outcomes and members satisfaction, you're not having any issues from the clinical side, right?
Not that I'm aware of.
That birth rates are over 2 now? Just kidding. Right.
Was that? Oh, yeah, right. The increased birth rate. Yeah.
All right. So we've already said add on this from an OEB point of view. All right, let's keep going. All right. So now we're going to get into the multiple or both boards here. A little discussion with this, Dr. Schwein.
Yeah. So, in February, we presented this stats, population stats, and why. So the menopause is significant of relevance to a substantial portion of our collective population regarding peri and menopausal health needs. So that was the rationale for adding this, and again, addressing the sort of continuum of women's healthcare needs broadly, making sure this was considered as well. So the reality is, current care with menopausal is somewhat constrained in terms of qualified clinicians, access to those clinicians on the medical care side. And obviously there's a whole bunch of things to support that woman through this journey with self-care and all those other things and the resources necessary to support that. So that's sort of what's encompassed under menopause support collectively. So the board goals, well, the question for SEOW is whether to make that recommendation to consider menopause support benefits.
Is this a broad spectrum coverage, as in like when fertility, there's like specific styles and specific things that we covered, some we didn't cover. When we say menopause support, are we covering anything that the FDA has approved that falls into this category? Is that just an overall thing, or is there specific like hormone replacement only or things like that?
There are multiple dimensions to it. So across both, at least for OAB, it is, Kaiser and Moda in terms of what their providers are addressing as part of their care continuum. It is the resources to support those individual women, whether it is educational, self-care, mental health services, so the wraparound services and capabilities. The treatment options are within the scope of the treating physician, right? So based on the evaluation of the individual risk, the symptoms, what they're trying to manage, I don't have a concern that those medications access are not within the current scope. It's just a focus on
there's no limits. There's no limits on it like we have for GLP-1, right? Where they're
not
only
special
under
limits,
certain conditions, right? This is open to whatever
that I'm aware of. Yeah.
Okay.
From a formulary, there's no restriction.
Perfect. so it's between the primary care doctor and the member, right? So, all right, opening it up to board members, both boards available for comment or question. Kimberly?
This is Kimberly. I don't have any question, but I do recommend add on the PEB side.
All right, anybody else want to chime in on their feelings on this?
This is Andrea from PEB board. I also support an add.
Dr. Laura, do you have a comment about this one?
I would like to add this.
Okay, and that only leaves Greg. I'm an add, just throwing that down. I forgot to say that at the beginning. Greg, did you have a comment?
Yes, I'm fine. It's an add for me. Thank you.
All right, so that was actually a comment section that turned into a roll call vote accidentally. So we're add on both boards here.
Okay.
All right.
The next one is unique. So what's on the table here is basically a continuation of our clinical efforts to support our members with a holistic and comprehensive set of resources and care to address cancer. And obviously skin cancer from a utilization cost always is one of the #1 in terms of prevalence and a significant cost associated with it. So this recommendation is basically helping, encouraging members to do what they need to be doing themselves as part of their skin cancer self-care. So obviously, when there's a suspicious lesion, we want that reviewed by a physician. But up to that point, it is about each individual checking their skin, identifying moles, identifying changes in any of their skin moles or lesions, and bringing that to the attention of their provider. This happens to be an app that's developed by OHSU, so it's a local academic center that has an app that's publicly available that supports that individual with that capture of an image of their skin lesion to make that cancer screening easier. So this isn't a plan design change, it's sort of an effort to leverage our wellness champions and channels and to bring more awareness to the membership on both OWEB and PEP side, and helping them do what each of us can do for ourselves with skin cancer screening and care. So the recommendation is to basically ask the OWEB and PEP boards to support this and communicate and encourage our wellness folks to disseminate, have that dialogue, and encourage our respective educators and associates to do what they can for themselves.
Roll up here with a technical question. Does the app, if we're going to say the OHSU app, I'm trying to figure out how the app and the primary care physician communicate. Does the app require an Epic account to put your data in? How do you do, or does it just collect pictures and you scroll pictures in front of your primary care physician?
So it is a dedicated app that captures images, and it has capabilities to track those images over time. So the things that we are asking patients to do, has the borders changed, has the color changed? Those kinds of things are just easier.
I get that.
So,
I'm saying, how does the primary care physician get the data? Do you need an Epic account to use this app so that it transfers the information to the primary care physician?
Currently, if you're a patient within the OHSU, they do have that connection. So it even includes the ability to schedule. Outside of that, it's going to be basically you presenting that image and showing, 3 years ago, this mold looked like this. Okay. Here's what it looks like now. Can you take a look? And the reality is the physician is going to assess the mold live anyways. But that history.
But they can see the history of it, but they have to scan it on your phone. So there's no transfer into your file if you're a Providence member, right? Okay, and is that a fair way of doing this? Is that if you were my primary care physician, would you be good with this?
Many patients do that themselves just by capturing the image on their own phone outside of an app. The benefit of this is it's secured within the app, so and it provides reference points. So a little bit more clinical parameters around this. But yes, I've seen and heard of patients that just do it on themselves and said, hey, this was what it looked like 5 years. This is totally different. Can you take a look at it?
Okay, and it's a valid input to a primary care physician, just
Yes.
using pictures. Okay.
It
Kimberly.
just augments what patients should be doing now themselves.
Yeah.
With a digital capability.
Okay. Kimberly.
So I have, I'm a skin cancer. I've had every one that you can have. I'm a gal that goes every 6 months. So I did download this app and I did use it. And so it's very easy to use. To kind of go to your question there, what you really would do is if you're not OHSU, you actually can upload, like when you're talking to your doctor on Epics, you can send the picture that you've taken. You could upload the picture because, you know, we have that ability to upload pictures in Epics. So, this is definitely, I think that this is really for those people that have heightened awareness about skin cancer and have, they want to really be on top of it so that they don't get caught. I mean, you still can. Melanomas likes to hide. But anyway, again, I've tried it. I try to do that as a PEB board member. Every time something comes up, I try to upload and do. And I do like this app. Thank you.
Does it give you a reminder like, hey, check this in the morning, right? It's been 6 months. It's been 3 months, right?
You can set reminders, yes.
You can. Okay. Other questions about, so basically from an OEB PEB point of view, though, we're just going to advertise the app saying, we recommend you use this app or another way of checking your moles for skin cancer.
Yes, and hopefully this, you know, is part of one of many ways that we can help our members sort of be more self-advocating for themselves.
Do we have a campaign for that, Dr. Chung?
Sorry, is there a campaign?
That would be, she's absolutely, yeah, that would be
We
more
have
for
a
staff,
campaign
right?
for promote, the app.
Yeah. Yeah.
So when I floated this up the flagpole with Teresa, you know, I think this was something for them to sort of incorporate into their schedule of communication and campaigns. So not speaking forward, but I can envision sort of a focus around cancer and then all the various point solutions and resources available. We communicate that and encourage the members of at the agency level or the entity level to take advantage of these things that are available that they may not be aware of. So a lot of this is just the wellness promotion and championing of our point solutions that and resources that are available. So I would look to them to do that. But yes, I see campaigns as being very useful.
I think we have a couple of campaigns that we do for early cancer detection, right? Gabby being one of them. Now this, I mean, we kind of have a whole shift left strategy for cancer early detection that this would just get added into.
Yeah.
Right.
And we're doing the outreach for colon cancer, right? So I think now we've got the 3 key cancers
the 3 big ones,
proactive.
right, in the campaign. Greg?
So I was on vacation last month, but I did look through everything. Question that I haven't seen that just really popped into my head is this. So we're looking to do this and maybe add. Is this something that comes with? Is this a new cost? Or, you know, is there a cost to this when we add it? As well as the last one. I didn't think about that for the last one because we know that coming up, you know, cost is going to be big for the next couple of years. So just a question.
So this is novel for us, and in the sense that there's no plan design change, there's no addition to the SPD and no cost. This is try to sort of do that wrap around and to Bill's point, just being more comprehensive on supporting our members.
That's fine. Some of the times in the PEB meetings, we have something that pops up and it looks like it should really be part of the plan. And then we find out that there's, cost in the end. So I try to remember one of the other PEB board members that's taught me very well to try to remember to try to get those up front so we can at least look at it. Thank you.
Yeah, this is another tool basically in the toolbox to keep members healthy to allow access to. Yeah.
So, for OEB goals, I would put this in the shift left education category in our goal. We're educating our members to track skin cancer on their own, and then get with their primary care sooner than later, right? All right, I think let me just walk the room again. So from the PEB side, let's start with Kimberly. Are you good with this? Add.
I am.
Campaign?
Add.
Okay, Andrea?
Yes, add.
Greg?
Absolutely add.
Dr. Laura?
Add.
And I'm an add. All right, so I think we're good on everything we're rolling with here. That was the one, right? Yeah, so now we're into behavioral health vendor. Yeah, good thorough discussion there. Really appreciate that. So now we're into the med. Sorry, behavioral health. Keep going. All right. Oh, wait a minute.
Thank you. Oh.
Behavioral health is okay. It's part of this, right? And we're still in this item 2 on the agenda. Is that correct? No, we're into item 4 now. Is that right? Somebody help me out here from Mercer. Did we just end item 2, or are we still in item 2?
Well, Bill, this is Glenn. That was the clinical recommendations for the upcoming plan year.
Yeah.
What we're in now is the vendor. What you're looking at is the vendor management or report.
Okay.
If you want to, we can take
that's
a
item
break.
4.
Yeah,
right?
we can take a break right now.
Well, the catch is we're half an hour ahead of schedule. We've only been here 38 minutes. Do people need a break? No, let's just roll. I mean, do we have everything we need to go to item 4?
Yeah.
Because we're half an hour ahead of schedule. Is everybody here, that needs to be here for item 4? It's a Mercer presentation.
Christy is here and ready.
Okay. And you're it? All right.
Awesome.
So unless I hear a yell from any board member, we're going to go right into item 4. All right. I see thumbs up. Go ahead.
Bill, I wanted to, before I get started, I just want to talk. So this is a larger part of our offering today. And I'm trying to think through if there's a natural break time that we want to have in there, or if you just want to let me know when you'd like to take a break. Because I think this is like an hour and 45 minutes is the time allotted.
Yeah. Let's target like 10-15-ish and find a natural point in your presentation where it's convenient somewhere in the 10-15 range. Is that okay?
That sounds great.
Okay.
And I might rely on others to just make sure that
I'll ping you.
Okay, great.
Yeah.
Thank you so much.
Yeah.
All right. Hello, SEOW members. So I have the pleasure today of being able to share with you our behavioral health vendor partner performance review. So if we can move to the next slide, please. And the next one. Awesome. First I'm going to set the kind of foundation for the conversation. And today we're going to be looking at these behavioral health vendor partners that are offered by each of the carriers. And this is part of this broader point solution performance management project. And it aligns really well with what SEOW does, which is looking at outcomes, value, and efficiency. And really our work on this broader project is to, really evaluate what these vendor partner programs are providing for reporting. We noticed last year there were very different reporting metrics that were shared. And so kind of evaluating that. And then also, as we look at key categories, establishing minimum standards for that reporting, and also for targets for improvement and areas that show of opportunity. And then we also have other vendor categories that are part of this broader project that we'll bring to SEOW at a future state. Moving on to the next slide, please. Okay, so I wanted to first talk about the goals for today and the focus. And so there is a lot of data here that we're going to walk through. And so, we really just wanted to level set. So for all SEOW committee members, today is really to look at the review of this evaluation from these partners, to take in a lot of it. There is a lot of data here. Discuss key themes. There are key themes that you're going to notice. And there's going to be insights that have also come up. And as we're walking through this, please start, thinking about what you would recommend as action steps based on these results. We have some action steps just to kind of get the conversation started at the end, but would also, as you're going through this, start in your mind thinking about those as well. So, and then for PEB members, there's a specific kind of goal for today is as we walk through this that considering the recommendation that you want to make regarding MODA's BH 360 program, which has been proposed again this year for PEB board's consideration. And you'll see those components that are part of this evaluation. All right, so let's move to the next slide, please. So as we talked about last month, this project really aligns well with both of the board goals. And, specifically these vendor partner programs oftentimes are augmenting and kind of adding to traditional benefits that are offered through the medical plan. They do close gaps in cares and oftentimes might provide equitable coverage across the state in a specialty focus area. Sometimes there's reduced cost to the members, or there could be reduced cost to the plan. And then also, again, these are really condition-specific programs, so oftentimes those improve member experience and, just support in these specific condition areas. To the next slide, please. And so first, just to kind of give a snapshot of PEB and OEB member demographics, some of the similarities is just, both plans have a little bit more females in the membership. And there's also large populations in the urban areas. But one thing to keep in mind, I think, is important here as we look at these different programs is that OEB has more than a quarter of the membership in a rural area. PEB has just around 15%. And then noticing the difference of the plans and the membership in each of these plans. And that just becomes more important as we're looking forward at kind of what is that engagement and utilization kind of target that we might be looking for. As we move to the next slide, please. One of the first things with this project that where we wanted to start is to look at the PEB and OEB current behavioral health claims data. Really to get a sense of where we're at. And so I'll kind of orient you to this slide because I know there's a lot of information here. So at the very top in the dark blue is the three carriers, so Kaiser, MODA, and Providence. Underneath those are the membership for each of those carriers detailed into OEB and PEB. And on the left side there, we show the number of members with first at the top, the total of members, and then underneath of there is going to be the prevalence of each of these conditions. And then we also have the total medical and RX cost. On the left-hand side of this table then, what we wanted to do is look at first the top behavioral health conditions that are showing up by episode within the population. And we use that term episode because it's just meant to kind of capture all of the costs that might go into treating that condition, whether somebody's seeing their PCP or getting a prescription, maybe they're going to a counselor or a psychiatrist. So it's a methodology that is used to capture episode. For PEB and OEB, the top behavioral health conditions are very similar. The first one on here is kind of a bucket of different behavioral health conditions, and it's called we call it other mental health disorders. It captures something called adjustment disorder, which oftentimes can be kind of a life event, and it also covers post-traumatic stress disorder, obsessive compulsive disorder, and some other things. And so it is kind of a broader bucket. And you can see that one has the highest prevalence. Below that, we also have then anxiety, then depression, substance abuse, and autism. And so those are our top 5s for PEB and OEB. And what this does is basically gave us the information that about 27% on average of OEB and PEB members have a behavioral health episode of care during this time frame, which is October of 2023 to September of 2024. What we also then wanted to do is be able to know, out of these members that have a behavioral health diagnosis, how many of them have actually engaged with a behavioral health provider or somebody who provides ongoing behavioral health care in the last 12 months. As we did that, we found that about 50% to 60% of these members had an outpatient visit with a counselor or mental health clinician, again, somebody who provides kind of ongoing counseling. A couple things here I just want to share about, again, with like national trends too, is so having about 27% of the OEB population with a behavioral health episode of care is a little bit higher than what we see in our national trends, which is about 1 in 5. And then also, we do know that only about 50% of people who could benefit from behavioral health care actually get the care. So then if we move to the next slide, it's like, okay, why do we do all this? And so really what we're trying to get at is understanding, again, if 27% of members have a top 5 behavioral health diagnosis, and 50% of them are not engaged with a behavioral health provider, this really equates to about 15% of the total member population that we're going to define as kind of the opportunity to engage in a behavioral health service. Now, this 15% doesn't mean that everybody, we're expecting the full 15% to engage, because that would mean 100% of people who have a behavioral health diagnosis would engage. And we know that that doesn't happen, but it just is trying to kind of start us as we're going into this project, and ultimately at the end, trying to develop our action step recommendations. What is the population we're talking about that we could actually be engaging? So that 15%, and this is about approximately 21,000 in OEB and 21,500 in PEB. Okay, so I'm going to move now to the next slide. And so looking at the behavioral health ecosystem for PEB and OEB members with the different carriers, and we're including Canopy EAP here as well. The great news and the good thing that the boards have each done in partnership with carriers is that there is a good spectrum of behavioral health services. And again, remember, these are all different than somebody engaging with like the behavioral health network through the medical plan. These are meant to supplement, augment that. And the way that we typically work in the behavioral health like spectrum and strategy is starting with prevention and resilience, going to navigation and treatment, and then looking at specialty vendors. And so you can see here again where each of these vendors that we're going to look at kind of fall. The other thing I want to point out here is going back to that kind of opportunity target that we talked about in the previous slide of that 15%. Typically in the prevention and resilience space, we might see that those offerings are going to apply to a broader set of the membership, because even if you don't have a behavioral health diagnosis, you might want to reduce your stress, or you might notice that sleeping is a little bit challenging these days and you want to really explore mindfulness meditation from Calm or something like that. So a lot of times these vendors in this prevention and resilience space might have a higher engagement and utilization. Then as you move to navigation and treatment, oftentimes those are people that are having a little bit more, maybe mild to moderate in that more possible clinical state. So there might be less people that are going to engage in the population. And then lastly, when you move over to the specialty category, we are going to also see here a much smaller percentage of a population that is going to engage, because there's only a certain percentage of the population that might need a virtual eating disorder clinic or might need an intensive outpatient program. So again, I'm just kind of setting the stage on as we start to think about what our next recommended actions are and what percentage of the population we might expect to be engaging with these different solutions. And so I'm just going to pause for a minute. I want to see any comments, or does this kind of how I'm setting the stage in this approach make sense thus far, or does anybody need or want clarifications?
Not seeing any hands are being raised.
Okay. All right. Okay, so looking at the evaluation then, what are the steps that we took? So going on to the next slide, please. So I believe last month we presented the top of this slide. And so our evaluation approach on the top left here, we are really following the clinical strategy approach. So we've selected what we're looking at, which are these behavioral health vendor partner programs. The yellow gold star at the assess is that's where we are right now. And so we've requested all of this data for our carriers. And I'm just going to take a moment and thank all of them, because we've had multiple conversations. They've given us a lot of information, and really appreciate the time and attention that it took to give us that information. And then lastly here too, then actions. So that's what we're working towards today is, after we see the high level findings, what's going on with these vendor partner programs, what are the recommended action steps that you all want to develop? On the top right-hand side here, these are again, these assessment categories that we shared last month that we're using for each of these vendors. Now, each of these vendors have different capabilities and different offerings within each of these categories. So you're going to see some variation as we start to walk through the different vendor evaluations, but these are the key categories. Now, the portion of the slide below, so this evaluation legend is new. This is kind of meant to be a guidepost for all of you. As we're looking at these different vendor partners, you're going to see there's a lot of information on these slides. And so wanting to provide you with some sense of green, okay, this area for this vendor is going okay. Yellow, it's a little below what we'd like to see. Red, we really should take some action here. And then gray is it's not provided. To kind of quantify what does expectation mean, right? So what does this mean, meets or exceeds expectation? As we went through and gave these kind of, I hate to say scoring, but it's a scoring guidepost, I guess, is that the expectation is really based on national trends and averages and what we know in our Mercer team of engagement, utilization, equity, and outcomes with these vendors in general and what they report. It also includes very PEB and OEB specific information that we learned from looking at the behavioral health data and current state. Where are you at right now? And then I will say also the expectation includes some limitations, right? Your PEB and OEB have a lot of these vendor partner programs through their carriers. And that's just a really different setup sometimes than what we see with these vendors with different organizations. So also just recognizing there are some very individual components of PEB and OEB that come into that. The other thing I want to say on the side is just as we're going through this, recognizing that this is the first presentation of this kind that we have shared with all of you for this vendor partner program project, and really wanting eventually feedback from you. Does this framework make sense? Is this, using this legend make sense to you? Does the information we're providing to you beneficial? So that we can always improve. We can always use this, and we love your feedback so that we can make adjustments going forward. If you're like, gosh, we'd really rather see this, or this would be more helpful. This is a dynamic changing process that we are always trying to reiterate and make better for all of you to get the information you need and ultimately make recommendations.
Opening up the floor to the board, I'll begin. With behavioral health, it's always difficult to metric something with evidence and outcome, right? Because how would you predict the future on a episode and where it would go into the future? And did you intercept and redirect that future into a positive place? Engagement and utilization are the two metrics the only ones I can, imagine that a member will not continue to utilize if they're not feeling benefit from it. I'm not seeing any other comments. Maybe that's just my tree that I stand under. I just like said, I'm not sure in behavioral health how you metric any other way than utilization. Enrique.
Thank you, Bill. I did had a question that's similar to your comment, and that has to do when they shared the slide of the demographic data of the rural and the urban part of the state. And it goes back to how do we predict the future? I guess I'm curious to know if we have this huge margin of the usage of healthcare, mental health, and the rural areas, which is an increase based on the data. Do we know why? We know access is an issue, but looking from the outside, well, it's not an issue because a lot of people are utilizing it more than the urban areas. So I was wondering if you can take a deep dive on that a little bit, and with this evaluation approach of the assessments I'm just concerned that we're going to make some assessments and recommendations and the data is telling us something that I'm surprised to see. I hope that makes sense. I guess my question is, how do we provide more support to the rural areas, yet they're the ones who get less services, but you're the ones with the most usage? How do you close the gap on that?
Yeah, that's a great question, Enrique. So I think what the data is showing us from this is that there is actually, the usage of behavioral health services, urban and rural, are both at a strong, it's a strong level for people engaging in services. With rural services, oftentimes, providing choice of modalities. So can we do more virtual providers, easy access to care? Oftentimes, sometimes it actually is an integrated behavioral health provider that's in a primary care clinic. You'll see in this evaluation that under the equity column, as much was available, we are trying to capture urban and rural members that are engaging in that solution so that you could kind of see the difference. And you're going to you'll see there's some of them that right now from the data that was provided to us, there is a gap of usage between the urban population and the rural that I think warrants a deeper dive as far as how is that being defined by the carrier to make sure, first of all, that the data is correct, and is there a barrier to engaging with a rural population in a virtual solution, or is it an awareness issue? Is it a communications component? So I think that there's a different pieces here that hopefully the way that we're going to present the data, and some of them, as I said, have this rural urban component to it, that we'll be able to make sure that recommendations aren't being made that are going to negatively impact the rural population. Does that answer your question, or am I totally off base?
You're on mute.
Oh, I think you're on mute.
Yes, it does help. Thank you very much.
Okay.
Although Enrique's comment kind of makes me think a little deeper. When we talk about equity and combining that with member experience, I'm wondering, not suggesting, wondering, if we bring in some social determinants of health factors and maybe some cultural background activity metrics, disaggregate that data a little bit by social determinants of health and the cultural question a little bit, to just see that we are achieving equity. That kind of is a little bit of rural urban kind of thing, but kind of saying that there are some issues with social determinants of health that are going to affect behavioral health, that maybe we should break that down a little bit. Just, I'm thinking out loud right now, so just take that as input.
I know, I think you're spot on, Bill, and I think recognizing too that, I'm oftentimes, right? So the therapeutic relationship is the number one factor that indicates, for a member thinking that they're getting better. That is like foundationally that therapeutic experience, regardless of the type of therapy that is being provided. That is one of the most important components. With that said, though, right, if somebody's meeting with a therapist, they're meeting with them once a week, maybe once every 2-3 weeks. And so think about everything that happens outside that person's time, that 1 hour with that therapist. And that's one of the hardest things, I think, from a clinical perspective, is to how you take that 1 hour of time with that patient and have them start practicing and integrating all of that into their life, and all of those other factors, right? It's a whole person that is dealing with social determinants with health, or stressors, family relationships, outside external factors. All of those components go into that treatment outcome. And that is where it gets really challenging. There have been huge strides made, I think, as far as measuring and reporting outcomes in the behavioral health space. There's still a ways to go. But you will see in this also that there are some differences on how, it's easier, I think, in some regards with some of these newer vendors that have come into play that have, they have one electronic health record that all their providers are on. They have requirements based on, and they do pay differently based on outcomes, based on clinical assessments, and they've been able to set all of that up. These providers came into the market around 2015, 2016, and they've been able to have that technology in place, versus a carrier that doesn't have, everybody's not on the same electronic health record, and they're relying on their providers for doing these assessments and then, submitting that information. So there is some variability for sure in how outcomes are measured and reported on amongst the different vendors.
It's difficult to integrate.
It's difficult.
When you're dealing with behavioral health, it's very difficult to understand.
Yep.
Right.
And I know we've talked about before too that like measuring A1C, that's easy for diabetes, right? We can measure A1C. It's something we can do, but measuring behavioral health and outcomes is just, it's a little bit harder.
Dr. Laura?
Yeah, I want to add a comment now that you mentioned a bit about cultural competence and awareness. I think it's crucial for behavioral health provider having that acknowledge. I just want to share, like being an immigrant and trying to find a provider specific for mental health that I feel identified and connected to that person. Then I'm going to share so important aspect of my personal life. It's been challenging. And I know a lot of people around me during COVID, this was crucial, right? So, and then we can transition to telehealth. But even though we have a lot of vendors, still it is kind of challenge. So one recommendation will be like how we assess the cultural competence from providers. Actually, it's not competence, awareness, because this is going to affect the impact in our members. So probably you don't engage as a member with them, because I see a lot of place to improvement here because we are not engaging members or they don't feel engaged or whatever. So I feel like probably that will be something to look at. Try to have that connection because the members, they don't feel identified with the providers. That's why maybe we have low rate of engagement. That's just like a note I wanna make. Thank you.
So basically take the engagement and utilization data one level deeper, kind of like an exit interview. When you have people turnover rates in your company, you want to exit interview to see why. Why is this occurring? Why is this engagement? Is that a fair state or refresh of your words, Dr. Laura? Am I getting it correct? Thank you. Right.
Yeah, and that's such an important component. I mean, again, I think that goes back to the therapeutic alliance and that relationship. And it's hard to get at. And, I think in Oregon, what we found, because we did dive into this kind of cultural responsiveness, that is requirement by the boards that oversee that licensure. They have the requirement in there of like cultural training. But how do you assess that? And I think right now it's an assessment with a survey of, check the box, I do this, or I've done this training, or for a small percentage of the providers, some of them will report their own race, ethnicity, language. But we know that that's challenging to get from a large portion of the provider population for various reasons. So lots of work to do in that area.
When we were presenting at the Ways and Means a week or two ago, I actually made a comment about this. These are difficult or not possible to measure the returns on behavioral health, flows, and gave them a few examples.
Yeah.
So
true.
All right. Any other comments? Let's roll to the next potential breakpoint, right? And then take a pause.
Okay. All right, so now we're going to dive into the individual vendor assessment. So if we move to the next slide. All right, so just some key themes to think about. We've kind of touched on a lot of these, but the level of member engagement, you'll notice, is a key theme. Outcomes realized is another key theme. And then really, I think we found as we started going through this that the next steps and some of the kind of recommended actions just also seem to be similar and a theme throughout. So just wanted to, again, kind of provide you some things to start thinking about as we dive into this a little bit deeper. So if we move to the next, so the first section that we're going to be looking at is that prevention and resilience. So if we move to the next slide, and this is how I'm going to kind of move through these different vendor partner programs, is through kind of that spectrum. So prevention and resilience. So the first one I'm going to talk about is Calm. Many of you might recognize that name. They have a direct-to-consumer offering and have been in the marketplace for a really long time, offering mindfulness and meditation. They have a lot of, they actually have some, celebrities that they work with. I think LeBron James might be one of them. So they, are really well known. And again, that's why we would typically see in reporting by Calm, will say that their typical book of business engagement is about 26%. So to show you how these slides are going to be, I'll orient you on the top right-hand side of each of these slides. The support type is the kind of category that they fall within. And sorry, this one says treatment, but it should just be prevention. The population is OEB and PEB. And then again, that 2025 opportunity is that 15%. And again, I just want to reinforce that this opportunity is not necessarily that we're expecting 15%, but it is that category of people that could benefit from engaging in this solution. Then we'll have on this side, on the left side, we have the engagement and utilization, which is one of those assessment categories. You can see here we have a yellow circle, again, just kind of indicating, oh, there's some room for opportunity. They have 3.7% engagement for OEB and 4.2% for PEB. And then a green under the number of activities completed amongst engaged members, just showing that once members engage, they are completing activities. There are some limitations that we have here, which is all these words on the left-hand side. Just with Kaiser, because this is a national contract, there was limitations to the group-specific data that we could get. If you look on the right-hand side, so this is some equity considerations for Calm. The top right is just showing that they have really good accessibility components as part of their digital offering. You know, they're WCAG compliant, which is that web content accessibility guidelines. They do have, you know, different accessibility components as part of their app. They do report that the diversity of their, you know, their people that are providing the different meditations and mindfulness are 50% representing Black, Indigenous, and people of color. And they have many languages available. Any questions on Calm?
Can they force your TV to only show rom-coms with happy endings for 24 hours? Turn the news off?
That would be nice.
See no hands.
All right. Okay, let's move to the next one. Okay, the next one that is also offered by Kaiser is called Headspace. Very similar to Calm. It is also has a direct-to-consumer offering, high quality content, same as Calm. You know, they put a lot of resources into the quality of the content they're offering because they are a direct-to-consumer offering. Headspace has, so they started as a virtual mindfulness meditation offering in the UK. And since then, they've really grown to a full behavioral health solution. But Kaiser, through their national contract, has the mindfulness and kind of meditation component of Headspace. And then they also have their text-based mental health coaching. Again, on the right-hand side, this one is really, at this time, what's available to Kaiser is the prevention component of this. Again, population is OEB and PEB in that same amount of opportunity. So now this one on the left side, looking at that engagement and utilization component, total members engaged, you can see, again, as a guidepost, it's at 0.6% for OEB, 0.7% for PEB. Huge opportunity here to engage more people in this offering. Headspace actually does report about a 25% average engagement rate. Again, that's in a direct contracted, oftentimes where Headspace is kind of the front door to all things behavioral health. So again, some limitations there. But the good thing you can see in the next one underneath the total members engaged is that once somebody engages, they are completing activity, which most typically also is a text behavioral health coach. Their coaches are all national board certified coaches as well. So they have a high quality content and engagement actually with members through their text-based coaching. On the right-hand side, again, the equity components as far as accessibility, they also are that WCAG 2.1 compliant. They do have other accessibility components as part of their app, and they have a variety of languages available. Now, one thing here I just want to point out, again, talking back to that 15% kind of opportunity of the population, right, is that Headspace and Calm overlap quite a bit in the services they offer. And so obviously Calm might apply to, you know, might appeal to some folks, and maybe, you know, if we got 5% engagement in that, but then another 5% maybe engaging in Headspace. So we kind of have to look at them, you know, as a full offering versus kind of individually when we're looking at that engagement and utilization rates.
Okay, so this is a market share opportunity, right? So there should be 15% between both Calm and Headspace is the way you're saying the 15%, right?
Yes, exactly. Yes, recognizing that
Mhm.
somebody's not likely to have both of these.
Right.
Yeah. All right, let's move to the next slide. Okay, so then this one we have Together All and Whole Life Directions. Together All is a peer support virtual program, and it is been in place for since June 1st of 2024. Both of these programs are offered by Canopy, and Together All as a peer support program does have some moderation by a mental health clinician. It is a text-based peer support program. And then Whole Life Directions is kind of a cognitive behavioral therapy program based in well-being. People will be able to kind of gauge their emotional wellness, complete a survey, and then they get personalized recommendations. Again, you can see at the top right, this really does fall into that prevention category. The population is OEB and PEB, and then you can see that opportunity that's there. Moving to the table under engagement and utilization. So these two programs, because OEB implemented Canopy as an EAP as of October 1st of 2024, there really isn't enough data to be able to provide good engagement and utilization information. So that's why we have that NA there. For PEB, with both of these programs, you can really see that those unique members who have engaged is very low, which is why we've indicated that with the red indication. So we have quite room for opportunity. Canopy is working with Together All on some engagement and utilization methods. How do we increase this? Making sure we're providing value to the populations, making it easier for members to access these two programs from the Canopy website. So more to come on that. You can see, though, under the PEB 2024 for Together All that 66 members engaged and they had 474 completed activities. And then the last thing I just want to share is we did ask Canopy for kind of their book of business utilization of these two programs. And so Together All for Canopy's book of business was less than 1%. And for the Whole Life Directions program was less than 4%. Any questions about this one?
So by your category of prevention and treatment, Canopy would pick up the non-Kaiser population, basically, right? Because there's Kaiser and there's Canopy.
Yes, and Canopy, yes, and even Canopy obviously is going to cover non-enrolled medical, members as well. They're open to the full population. That's the beauty of an employee assistance program. So there's, it's and it's no cost to the member.
Yeah. But Canopy is only app-based, right? So that's their.
These two programs from Canopy are digital-based programs, yes. Now, later on in more of the treatment segment, we'll talk more about the Canopy clinical programs. But yes, these two.
I'm just talking about in prevention treatment category that you've created here.
Correct. Yeah.
Anybody else on the board with the comment that we're going to take a break now? We'll move into the next category of treatment offerings after break. Any last comments from the board?
Oh, this is Andy. Just a real quick, I just want to say that just looking over all of this, that the combobulation of vendor with more vendors in it is really like, it just seems like everyone's kind of, I'm now borrowing from someone on PEB that has taught me well, like it's just kind of convoluted to have a vendor that has a vendor that has a vendor. And that just makes me wonder how much those administrative costs go up. And then the concern of like kind of quality and whatnot, but that's just a comment that there's a lot of hands in this pile. And I think that you know, I'm just curious how effective, as we're looking at, is this?
Yeah, it's a specialty world, especially in the behavioral health, where it's hard to have, you know, a behavioral health methodology in every provider, in my opinion. But at the same time, are we too many levels of specialty work, which makes it hard for the members to say, okay, where am I going with my issue that I have, right? How do I navigate this, right? And I think we'll get to that when we get through the next two categories that Mercer is providing here, and then combine it all back together and say, okay, how does a member actually walk through this process? Ollie?
Thanks. Just a quick comment. I think, you know, you see a lot of vendors contracting with other vendors, and a big reason for that is we, PEB and OEB staff are bound by public procurement rules. So it's really, we have to go out for, you know, extensive RFP it takes a lot of resources to do that when other RFPs are going on. So oftentimes, you know, it's easier for the board to talk about kind of what they're looking for and have the contracted carrier go out and secure that. So that's kind of one of those. Yeah. Thank you.
Andrew?
Hi. Yeah, Andy, I think your comment's really well made, and frankly is a big part of the reason that sort of kicked us off on this journey to evaluate these subcontracted point solutions and really sort of bring more active management of what they're doing. How are they doing it? Are there integration concerns? What's the administrative sort of perspective? And so, you know, today we're talking about behavioral health, but in subsequent years, we'll be talking about other areas, whether that's MSK or cardiometabolic, because like Ali said, based on how the boards are set up, there's a lot of these subcontracted point solutions. And so I think you're exactly right in your observations that, you know, with that, there are pros and cons. And so this exercise hopefully will sort of shine a light, like, well, how are these solutions doing?
Perfect. Thank you both.
Yeah, and thinking about that a little bit, I mean, what are just, so we choose Canopy, right, for our EAP vendor. Do we have a lot of say in how they deliver? Like, can we sit there and say, you know, hey, your whole life direction, we love Together All, but your whole life direction is I mean, what is our say in this as we are actually contracting with Canopy as our EAP vendor? Ali, you want to take that one on?
Yeah, I mean, I would just say Canopy has been super responsive. You know, I think for PEP going back a few years at the start of the pandemic and just always being there to take input from members of gaps, and they've been very responsive in adding certain things, bringing new services on, and now with OEB, I think, you know, the same kind of partnership. Been very, very impressed by that.
So we're basically, and not just Canopy, I'm talking about everybody in general. We're basically on the subcontractor part like this, we're just feedback, right? We're like, hey, you know, Canopy, we got you, but your one program is insufficient in our opinion in these areas. That's our world. That's what we do, right? To get
That's
that
the
correct.
world. That's the world, but I wouldn't underestimate the
value of that.
Leverage of PEB and OEB, and just, you know, what the boards want to do. I think that means a whole lot in that world, and I think people respond to that.
But we don't have to yell at each other in the White House to make something happen, right? Yeah. We can actually have civil discussion here and get some good points made, right? Yeah. So, okay, cool. All right, why don't we come back at 10:35 if that's okay with everybody? 10 minutes, 10:35. All right, see you in a minute. Didn't realize we had 48 people on this call. Wow. Is that your extended family, Ollie? Is that how you get so many people on the list?
Usually it's over 50, but
Is it your softball team?
Holidays might be fun.
I did play a lot of softball, ironically.
All right, let's see about bringing us back into action here. Oops. Okay, we're back.
Okay.
Who was sharing for you, Christy? Oh, there she is. Maya was sharing. That's who it was. All right. All right. So somewhere around slide 29.
Slide 29. At navigation and treatment, I think, is where we were.
Yep, there we are.
Okay. So we're going to move on now to that next kind of category. And so first here, and again, in this category is navigation and treatment. Some of these vendor partners offer a little bit of both. So that's kind of, we'll see a little bit of an overlap there. So first starting with our BH360 Champion program, this is offered through MODA. In the top right-hand side, again, navigation only. The population right now is OEB. This is proposed for PEB. So this is one of those earlier for our PEB SEOW members thinking about the proposal in our renewals. And then again, that target opportunities there. And so the BH360 Champions is a dedicated team that provides navigation support to members, helping them find providers. So what we've talked about and with Dr. Lara, they really help find providers for members that match their needs. And they will vet availability of that provider and also perform follow-up. And so as we look here, so in the table, the first category we're going to look at is engagement and utilization. And you can see here that, so total members engaged, for each of the populations is less than 1%. And then the number of activities completed is really like, once somebody engaged with the BH360 program and the champion, how many of those members made an appointment or had an appointment with a provider. And so that does show that they're helping, about 63% of those people connect and make an appointment. Couple things I just want to caveat here, as we were talking with Moda a little bit about this, is that obviously not everybody who calls into the Behavioral Health Champions program, they might not all be in the position or wanting to make an appointment with a provider. They might have some other questions that they're trying to solve for. And then the other component too is as we look at the next bucket, which is the member experience, you can see here average wait time to appointment is in that 32, 33 day range, which is, that's much longer than we'd like to see or that we see within our kind of market standards. But there's also some caveats here where, somebody who calls in to see a champion, the way they measured this was kind of looking at the data. So when was the first time that person had an appointment with a counselor? And so there could be some other varying factors that would lead to this kind of longer time frame. But typically we'd like to see it much shorter. Another component here could be specialty. We know that sometimes somebody might be reaching out to a BH360 champion because they're really trying to get in to see a specialist. They might be trying for applied behavioral health analysis, ABA therapy, or something like that that has a longer wait time. The modality of care, you can see here, is a little less in person versus virtual. They weren't able to provide us kind of the number of counseling sessions once somebody engaged with a provider, but you can see here participant satisfaction. So in that 62 or 60, and NPS is the Net Promoter Score. It's something that's used across different markets and industries, it's really an indicator of customer satisfaction based on a single question, and above 50 is considered good. And so if we move to the next slide, okay, so then the equity components with the BH360 Champion program, the demographics of engaged members, the things here just to call, I mean, so about 63% are female. You know, that tracks somewhat with the population of PEB and OEB, and also what we see for utilization of behavioral health services in general. It typically tends to be higher females. About 35% are ages 18 to 39, and 49% are ages 49 and up. This is one of those little areas that I talked about before, is recognizing in the data that MODA provided us, 99% of those engaging were indicated as urban. So I think this is one of those areas that we need to do a deeper dive to see what's happening there. And I know MODA is already working on that from our earlier discussions. We also are able to, because MODA collects race, ethnicity from members, we are also able to see what the engagement is there. So some, you can see different demographics are engaging with the BH360 program. We are also able to capture language preferences. One thing in the data with language preferences from MODA was just that typically that unknown category or did not indicate a language other English, then kind of that box isn't checked. So we're just it's like they didn't check that they needed a different language other than English. And then the provider search capability. So this is, you know, a good component of the concierge program, is that they do support members in finding a provider that meets their needs, whether that's, you know, culturally responsive needs, language, gender, or even clinical specialty. Any questions about BH360?
That urban number really is striking. Actually gave me a memory of an old movie. Crocodile Dundee, the original one, when he's telling the woman that, you know, when you live way out in the middle of Walkabout Creek, you got a problem, you go to the pub, you tell Wally tells the bartender tells everybody, and your problem gets resolved. And I just had that memory of that scene. Right. But yeah, 99% urban. Is that a well, that's just head scratching. Right.
Definitely. And I think it's one of those, again, it's one of those things that doing this evaluation brings value to uncover that, like what is going on there. Because that's definitely an area of opportunity.
Could the possibility of BH360 being a second order factor? In other words, I'm a member of MODA. I know where I want to go. I've had friends tell me it makes that I try to go there, I get in. And if I don't get in, well, maybe I should then call the BH360 champion, because now I'm stuck so it becomes a second order thing, right? Kind of a mode operandi. You know, that's how this is working. I don't know that. I'm just wondering.
I mean, I guess I just have my anecdotal opinion on that, is that I would think we'd see that across urban and rural, though. I don't know if that's a specific, you know, so again, I don't know if it's I don't know. Again, I think it's something that we have asked in our conversations, just to do a deeper dive with MODA into kind of what that is.
Or is that movie correct? Your local pub bartender is the best psychiatrist in town. That's where you go for psychiatric help.
Yeah.
So.
There is actually there is a lot of research to show that in different populations and different areas, that, you know, some people find their care in, you know, their spiritual community or in their cultural, you know, neighborhoods and communities. So
True.
Yeah.
I don't see any other hands up. All right.
All right, next one. Okay, the next program is the Behavioral Health Consultant. This is through Kaiser. And so the behavioral health consultant, so this is different. And that's, I just want to make sure I'm also talking to the differentiators of each of these programs. And so, you know, with Kaiser and their integrated delivery model, a behavioral health consultant is really integrated into the primary care service that a member receives. They are licensed clinicians, and they're offering really brief, like solutions-focused therapy, and typically 1 to 3 sessions. And so a program like this that is more integrated into the primary care office, we would tend to see higher higher engagement, because we know that the primary care physicians there, maybe that person has done a screening as they're coming into their appointment for depression or anxiety. They score a little bit higher. And right there and then, that primary care provider can do a warm hand transfer to that clinician. Or if the clinician's not right there, then they can say, hey, we have this great behavioral health consultant. Would you like them to reach out to you? And they can, you know, they can support you and get you connected with care. So higher engagement is expected in this. And so you can see here with the total members engaged, 2023 for both populations around 5%, and then 2024 in that 6% range. And then the number of activities completed amongst engaged members, this is that, you know, again, for that 1 to 3 sessions, how many of these members engaged or outreach that was needed. The other thing a behavioral health consultant would do is obviously say if the member had a higher acuity of need, then they would also kind of help that member, guide them, or even do bridge kind of support while that member was waiting to get engaged with a higher level of care. We weren't able to, Kaiser didn't have average wait time to appointment. Again, sometimes it's right there and then, other times it's a follow-up. You can see the modality of care deliver. So certain percentage in that, you know, quarter percentage, 24% in person, a little less than half is virtual. And then they do have a chat function as well that they're able to chat with a consultant. Average number of visits in that 2, which fits their focus area of this solutions focused interventions, 1 to 3 sessions. And then you can see there's high satisfaction reported from participants. And this is on a 5-point scale, those who reported 4 or more. If we move to the next slide, please, then we're going to be looking at the equity components of this. And so changing it up a little bit with a graph here, so you can just kind of see what the engagement is for different demographics with BHC. And then here, as I look at equity, so primarily female again, in line with the PEB-OEB populations, and again, with the higher utilization, females just utilize behavioral health services higher, but that doesn't mean, I guess I'm going to do a little aside. I have worked with some organizations that do some specific communications and outreach specifically for other populations than female to engage in behavioral health services. 85% urban. This makes a little bit more sense though with Kaiser, since Kaiser primarily falls within urban populations. And then you can see the largest age group is that 19 to 44-year-old. They are capturing languages that are spoken by the members. And then the languages that are available from behavioral health consultants, mostly English, but they do have some of the BHC speak Spanish. And then of course there's interpreter services that are available through Kaiser. And then provider search capabilities, though. So this is an area where the members don't get to really, they can't search for a provider or necessarily have the ability to match with somebody that meets a lot of their own needs and preferences. Or at least that wasn't provided to us from Kaiser as an ability. Any questions on this behavioral health consultant program?
Not just for Kaiser, but in general, is there like state law on health specialists or things that how many you have to have, or patient ratio or anything like that? Is there any kind of work or legislation being done to try and reduce the turnaround time, the appointment time?
There is. we did through IWG, we did our behavioral health, we did some standards on wait time, kind of network of providers within the geographic areas. So those are in place with kind of target measures as well. And so we followed a lot of the Oregon Medicaid standards that are set up for this, and when we presented those and kind of defined what those were with IWG group.
Is that in the last 2 years?
It was last year. Yeah, we can send that out as a follow-up as well.
Interesting.
that you
My
had those.
my curiosity is about whether that's driving up some of our healthcare costs renewals because of that.
Because of the higher
Okay.
utilization of outpatient behavioral health services, or
And the requirement to have more professionals on staff. So suddenly I see hands going up. Glenn, your hand went up first.
Yeah, and I would just say that there are network standards. They are pretty, I would say, pretty loose right now and for behavioral health, but there is a bill to where the what's called DCBS, which is the Department of Consumer and Business Services, would establish more detailed standards for behavioral health and some other professions too.
Margaret?
Yeah, hi, let me see if I could get my camera going. There I am. Yeah, so just to add to what Christy had noted, so we did, with the innovation work group last spring, identify those behavioral health access and wait time standards. And so those were incorporated into our carrier contracts this contract year, being the first year. And this first year is a report only year. So there are no fees at risk. We will see kind of baseline level data will be reported by the carriers later in the year. The reporting timeframe is this summer. So it'll be kind of more the second half of the calendar year when we'll have that initial baseline data and be able to kind of take like a more deliberate initial look at that. The innovation work group's goal was to take a look at the baseline data and set targets so that in subsequent contract years, we would actually have a performance guarantee and some fees at risk for achieving those targets. But as of yet, that work has not been done as we're still in the process of capturing and then later on reviewing this initial year of baseline data.
Yeah, it'd be nice to make sure we have that on our spreadsheet of SEOW for next year, that IWG kind of present that those initial data to us just to understand it better, deeper.
Yeah, that can, yeah, absolutely is an important addition to the work plan. Agreed.
Yeah, excellent. Anybody else? All right, let's keep rolling.
Okay, our next program that we looked at is the Behavioral Health Concierge. This is offered by Providence. Just to clarify, so this is a program that provides treatment. It is for PEB. And again, we've kind of quantified that 15% opportunity. So this is telebehavioral health consultation services. It is through the Providence Behavioral Health Network of providers. It's through 7 a.m. to 8 p.m. Pacific time with licensed professionals. And it is really designed, again, for mild to moderate behavioral health needs. Again, if somebody had a higher acuity need, then the behavioral health provider would, help navigate them to that. So here is our information for engagement. Total members engaged, you can see again, less than 1%. The total visits that were completed. It's interesting though that based on the information provided, the average visits per member are actually higher. You can see here, around 8 visits per member in 2024. And that's a pretty clinically significant, we typically see that for most people that are engaging in counseling, that, it's around 80 to 85% of people can get their needs met in kind of that 6 to 8 session mark. For the member experience with this program, that average wait time to appointment is about 7 days or less for, in 2024 for 87% of people who engaged. It's 100% virtual and relatively high participant satisfaction at that 86 level. And again, that's that Net Promoter Score of NPS. If we move to the next slide, the equity components of this. So 98% are ages 26 plus. And again, that can be just, again, engaging, though that membership oftentimes, especially people in their teens don't necessarily engage directly with the health plan. They gave us a breakout of the members engaging by county. And the understanding from the information provided from Providence is there isn't really a provider search capability to be able to find a provider that meets a member's needs and preferences as far as race, ethnicity, language spoken, or gender. And some of the outcomes that were shared by Providence, the top conditions that they're seeing for folks coming into this program is stress, anxiety, and depression. So really, again, those top 5 behavioral health conditions. And then you can see clinical improvement. So about 50% reduction in depression identified versus that PHQ, which is the depression clinically validated assessment, and then about 47% reduction in anxiety for using the GAD, which is the clinically validated assessment most widely used. All right, next slide, please. All right, so Spring Health, this is an offering with MODA. This Spring Health is one that actually offers, they do have navigation with their care navigators and then also have treatment. This is available currently for OEB and PEB members. And so this is set up, so Spring Health, I know Bill, you mentioned earlier, right? They were one of the vendors that was looked at previously with our RFP for the EAP. So they're a provider in the network, but they also oftentimes are set up through the medical network, kind of as MODA has, which we call it's a client-specific network. And again, it's meant to augment the current behavioral health network that MODA has in place. They do have licensed counselors and psychiatrists, care navigators that do help with a member navigating to the care that they need, finding a provider. They also have self-guided resources, so somebody can go into the Spring Health platform and register and really just look around at all of the resources and do some self-guided things. One of the unique things I'll just say about Spring Health is that they do have the electronic health record is required for all of their providers, and all of their providers have an updated bio. So they have their picture, they have, their like a little description about them. So it really does allow members to find a therapist that they think would work for them. So you can see here again in this engagement and utilization, our first section, that total members engaged, it's nice to see for OEB, it was in place in 2023 and 2024. We can see a 1% improvement in engagement. That's great to see. And then with PEB, their first year actually in 2024 kind of mimics what OEB had in 2023. Total percentage of members that are assessed once they are engaging. So once somebody engages in the Spring Health platform, again, they can just kind of peruse all of the self-guided resources, but they can also then kind of engage in that finding care where they would perform this assessment, which is a digital assessment tool. It's very smart and, depending on somebody's answers, to kind of takes them to the next question. It does use the PHQ-9 for depression, GAD-7 for anxiety, and I know they have other clinically validated assessments as incorporated in this as well. You could see the services completed, the total number of appointments, and then we wanted to also, they were able to provide us information on the psychiatry appointments, which I thought is always an interesting piece just to look at. As we look at member experience, so for Spring Health, they do have really fast access to care. Less than 2 days is really what they typically have the guarantee. And you can see that rings true here, PEB and OEB. The modality of their care delivery. So they have about anywhere obviously here from 8% for PEB or 15% for OEB as far as in-person. So they do have some in-person providers. And then in that about 85% is virtual. And that is what we see, I would say, with Spring Health, also with other organizations as far as that engagement modality. The average number of coaching counseling sessions in that 8 to 9 range, again, another good metric to be looking at, that people are engaging and hopefully getting the care they need. And then really high participant satisfaction score there, 9.3 out of 10. If we go to the next slide. Okay, so then looking at equity, so we have a green and a yellow here. And so you can see demographics of member engaging. Higher female again, a little bit high on the OEB side, I would say, a little bit higher than what we see in the population. We can see that, interesting that there is a small percentage that are under 18 years old. And again, though, that little point of saying that 98% urban. So again, this was one of the programs that we asked for MODA to do a little bit deeper dive into this urban versus rural utilization. Spring Health does have a pretty wide variety of demographics of their providers available for members to choose. In MODA's collection, or how they members would indicate the language preference, it was majority English. And again, they have that really robust provider search capabilities that's available. Spring Health has outcomes that they're able to, and again, this is one of the vendors I talked about earlier where they've been able to set themselves up from their inception in 2015 to really have outcomes-based measurements as part of what they do. They have all their providers on their platform. They actually offer great supports to their providers as terms of supervision and some resources. So 80% for OEB, clinical significant reduction in depression, 76% anxiety. And then for PEB, 76 reduction in depression and 66% in anxiety. All right, I'll move on to the next slide. I'm watching for hands in case anybody has comments or questions. Okay, the next program we have is called Maru Health. This is also an offering from MODA. Also, again, primarily treating stress, depression, burnout. It is a more structured program, though. So it's kind of it's a 12-week program with more structure. Each member is paired with a therapist. They also have it's based in cognitive behavioral therapy, so they have these self-guided daily practices. And one of the things of cognitive behavioral therapy is to have homework kind of in between sessions, and so that's where this kind of in between daily practices come into play. And then the interesting thing about Maru that I don't see with the other vendors is that they do have a biofeedback device that's also sent to members. And this is, I think, either it's a finger or an ear sensor. I think if somebody can't use the ear sensor, they can get a finger sensor. And really what it's doing is it's detecting pulse. And so it's really giving that member real-time feedback and information on their body's response to breathing exercises, so that they can see that, oh, I can actually, help bring down my emotional distress that I might be feeling at that moment. And they also have a peer community that members can engage in. It is for ages 18 plus. And so again, looking at that engagement utilization, you can see, low utilization, again, below that 1%. High engagement, though, with assessment. So of those people who are engaging, their first, interaction must be positive because they're moving on to the assessment portion of it. And then we have unique members that have completed a counseling session of those engaged members. which is why my percentages changed there. So you can see that the assessments completed, the unique members completing a counseling session and completing the program are all percentages of those that are engaged. And then as I move down to the member experience, you know, a couple things here we look at. So average wait time to first appointment, 2.5 days. That's a good metric. That's, you know, standard with what we'll see with these types of digital programs. Average activity engagement. So across the programs, they were able to provide us about 15.5 hours that members are engaging with a therapist or with the peer support program or self-learning, and high member satisfaction at 96% based on their satisfaction measurement. And then if we move to the next slide. So equity within this program, I think the two things I'll call out here is just right now the program is as English only, but Spanish is on the roadmap for 2025. And then it was reported that provider search capabilities aren't available. So again, one of those components that we think is important for equity is to have the ability to find a provider that meets your preferences. And then they do have outcomes. Again, using those clinically validated assessments, the GAD-7, the PHQ-9, you can see that they are able to report on reduction of symptoms. Any questions on Maru Health? All right, we can move to the next one. Okay, so we're going to move. So Talkspace, again, this is probably one of those programs that maybe you recognize the name. This is offered by Providence. Similar where it's augmenting their current behavioral health network. And it is for ages 13 plus, and they have 32 languages that they offer. And it is virtual. So if we look again at the first boxes there under engagement and utilization, so unique members who engaged, again below that 1 percentage point, and you know, you can see members who completed 1 visit. So really, when you engage in Talkspace, you are really engaging in a service with a counselor. Average wait time to appointment is in that 6 days. 100% virtual. And they were unable to, at this time, provide participant satisfaction. Equity components, again, the demographics. This was an interesting one that I just wanted to highlight. So for Talkspace, as reported by Providence, about 44% of those engaging are ages 13 to 17, and 41% are ages 18 to 25. Super interesting because it's very different than some of the other programs. I can only just, again, kind of opine in my own experience of Talkspace in the market. They do a lot of marketing and outreach and programming within to teens on social media. Also, they have some partnerships with some local governments, like New York City is one of them. So I don't know if there's some recognition by that age group, but just an interesting point that showed up in the data. And I know, Bill, you had asked previously about teens and kind of services particular for that age group. And then also members can search for providers that meet their needs. And they have outcomes that they can show. 75% reduction in anxiety and depression. And then they actually are able to also look at significant improvement. And there are, I will say there are standards around what is improvement versus what is clinically like significant improvement, which typically it's defined by all the research that's done using PHQ-9 and GAD-7. And for example, like clinically significant with a PHQ-9 is that the score is under 9, and oftentimes it has a reduction of 5 points from the pre-assessment before treatment. Oh, is anybody interested in the age range for Providence like I am for Talkspace?
I noticed the last one also wasn't teens, but it was servicing younger people the most.
Mm-hmm.
Not by a whole lot, but definitely
Yeah.
noticeable in Maru. It was right.
Yeah. So it is. It's just interesting, I guess, to think about. Again, as we're talking about the spectrum and all of the different programs that are offered, there's a lot of member preference or member knowledge about different names that maybe, oh, I heard this was a great program, or, and that kind of drives us to that care.
What I've been noticing is that, so, I'm sorry, and this in the previous slides is that the rate of usage has increased on populations overall, just like your member engagement, right?
Mm-hmm.
So I've been wondering, I don't know how to say this, but I feel the society after COVID is relying more on mental health services, but work environments are becoming more toxic and more, maybe toxic is too strong,
Mm-hmm.
but I'm describing what I see and what I'm hearing in the environment in society. It's becoming more confrontational. And so I don't know if that's the reason why we have more healthcare services requests, but or they're correlated to the pandemic. I don't know. I'm sure somebody's working on their PhD on that, but that's my observation.
Well, I think your observation is spot on as far as so we are seeing a huge increase, obviously, in mental health utilization. We've seen since the pandemic stigma around accessing care go down. Stigma has reduced, particularly with accessing care for anxiety, depression, stress, burnout. I will say substance use disorder still has a really high stigma for reaching out and getting care. But in those, again, anxiety, depression, stress, we have seen the stigma reduce. But I think you're right. We are seeing also, and I know our Dr. Nelner, who works on PEB with well-being, also has presented, that work has really become a social determinants of health because of the environment and some of the demands that are put on workers. So. And I guess even Enrique, I'm thinking more about too, I think specifically within education, I think there really has been a heightened level of stress. I mean, I have an educator in my household, and I know we share what did we do today at the end of the day, and it's vastly different. And I just, there is a high level of stress, and some of the current things that are going on with immigration policies and schools, and putting administrators and educators in an interesting position, along with our families that are in schools.
Thank you.
Yeah. Okay, I'm going to move to the next one. I don't see hands up. Okay, so Canopy. So this is, we're looking at canopies, and this is specific to their clinical services that they offer. And so clinical services too also encompasses their coaching. This is for OEB and PEB, but also I just want to recognize that OEB is super new data. We only have, October. I think they gave us 4 months. It was like October 1st to January 31st. So just we've annualized the OEB data here. So you can see here, if I look at the unique members engaged in the engagement and utilization levels there, that for clinical services, they are in that upper 3s to 4%. And that's, for an EAP, high touch, of what we would call Canopy being high touch, because they do offer scheduling assistance. They vet provider availability and really do help that member find a provider that fits their needs and does follow up. In this 4% range is a good engagement for, again, an EAP clinical utilization. You can see the number of individual services accessed there. Again, that encompasses like number of counseling sessions, coaching sessions that those members who have engaged have done in total. Member experience. So average wait time to first counseling appointment, they were able to provide us for PEB in 2024, that it's in that about 7.5 days. The modality of care delivery, again, in that mid to high 30% range for in-person, 53, 54% for virtual. And then they have the telephonic, which oftentimes is that in the moment counseling. Somebody calls into the 24/7 line, is experiencing, some distress and wanting to connect. And then they do have a text chat function, and you can see the utilization there of that. Average number of counseling sessions per unique member. The only thing I'm going to say here is a little bit taking this with a grain of salt, because in the PEB population, there is much variability in the number of sessions that are available to the members. Some agencies in PEB only have 3 sessions available. Some have 5, 6, or 8. So that obviously is going to drive this number. So there's some limitations to looking solely at that number. And then you can see participant satisfaction, those that responded to 4+ on a 5-point scale. And again, I just want to caveat, OWEB is really a very small snapshot of their experience thus far. Okay, next slide, please. So equity with canopies is different for OWEB and PEB, and the reason for this is because with OWEB being implemented 10/1 of 24, we are exploring collecting the demographics of members engaging. Because Canopy has been placed with PEB for quite a while, this was not part of the system that had been set up. And so we thought it would be a good opportunity to practice with it with the OWEB population, and then roll it out as the legislative requirements are, asking for collection of the real DSOG data. So that's where you can see here on the left side with OWEB that they are collecting this information. Again, brand new data though, so I wouldn't say that it's information to make decisions on, because it is reflecting only 4 months. With PEB, you can see, again, I think it's interesting just again that the age range that is engaging. And then with provider search capabilities, as I said, they do have the ability to help a member find care, matching their preferences, their clinical needs. They also do follow-up to make sure that that member did connect to care. And then in the outcomes category, for OWEB, you can see top clinical conditions there. And I'm sorry, I think those should both be yellow. They should not be different. One should, under outcomes. And really for this, collecting outcomes again within like an affiliated counseling network where everybody's not on the same electronic health record, it's harder to collect those outcomes. And so they were able to share their 2024 book of business outcomes. And so there's that 74% decrease in depression, 85% decrease in anxiety using those clinically validated assessments. Another one of the kind of outcomes we look at specifically when we're looking at EAPs is what percentage of the cases are able to be resolved within the EAP. And so that metric for their book of business is 82%. All right, questions on that before we move into the specialty?
Just out of curiosity for my education, the housing support, what does housing support mean in the Canopy employee assistance? Just trying to understand that.
Yeah, so the work-life needs, so housing support oftentimes might be, and they do a social determinants of health screening. So if there is identified that somebody, when they answer one of those questions, if they have stable housing, and they're going to connect them to a community resource, most likely,
okay.
To say, hey, this is available. Have you checked with this? Yeah.
Okay, so just okay, we have a local group that does that for our region. For housing support I'm talking about, but I didn't realize that was also covered in these kind of things.
Mm-hmm.
Okay.
Yeah,
Got
they
it.
have a database that they can connect for local resources and yeah, different depending on what that member's needs are.
Mm-hmm. I don't see any have their hands up. So on to specialties.
Specialties. Okay. So just to set the stage for specialties, as I said before, this is the area where we're getting now more into smaller populations that would actually engage, because a lot of these programs are going to be based on a diagnosis or a specific behavioral health need. So you're going to notice in the top right that we've changed the opportunity percentage, just to, again, be a little bit more reflective. And again, that opportunity percentage is not necessarily saying that we expect 3% to engage with this population. We're just saying that that's kind of the opportunity. We want to then define more maybe targets that we're working towards. So Charlie Health is a virtual intensive outpatient for teens and adults. It does have connection with a primary therapist, peer support, and resources for family members. It is for ages 11 plus. And oftentimes, like an IOP program can oftentimes be a step down. So if somebody's been in an inpatient or had like an acute need, and then they need a higher level of care than like outpatient, seeing a therapist once a week, then an IOP is a great place for somebody to go. This is 100% virtual, which is also another interesting offering, because oftentimes what I found when I was doing direct patient care, there is hesitancy to do an IOP that is, you're going in person every day to someplace and doing classes all day. This allows for people to kind of re-engage a little bit more in their life while still getting this more intensive care. So unique members who engaged in services, you can see here, and we kind of broke it out to those under 18, those above 18, members who completed at least one visit. Again, a lower engagement metric. We know that about 5% of the population has what we call a serious mental illness, and not that are the only folks that would engage in Charlie Health, but again, we're talking about a smaller percentage of the population that would have the clinical need to engage in an IOP. Member experience, it's 100% virtual. We don't have participant satisfaction metrics. And then for the equity components, a couple things here, just kind of pointing out, again, that higher urban percentage of those that have engaged, higher female, but again, that follows kind of what the population is. But it is for that interesting age range. I think that's it's great that there's a program like this for members that are 11 years and up to engage in. If we move to the next slide, please. So Charlie Health is also offered through Providence. Same program. And so you can see similarities, right? I think the engagement, is around the same level. Age ranges also, again, it's in the, really serving that 13 to 17 range, and then 18 to 25. We did get some different information from Providence a little bit, just that obviously translation services are provided, and then they do have some Spanish IOP programs or groups that they offer. And then the top conditions, so they don't have outcomes to report, but just recognizing some of the top conditions, again, are some of those just higher acuity, depressive, anxiety, but then also bipolar, conduct disorder, reaction to severe stress. All right, let's move to the next specialty program. Okay, so EQUIP is with MODA and Providence as well. EQUIP is a virtual eating disorder program. They do use a team approach for treatment. Eating disorders are a very challenging behavioral health condition to treat. And so oftentimes, and it does obviously encompass physical and mental health. And so oftentimes treatment teams do consist of, a physical provider, nurse, psychiatrist, nutritionist, and then therapists as well. They also, one of the interesting things too about EQIP is that they do co-occurring treatment. So anxiety, depression, because oftentimes they can go hand in hand with eating disorders. And so again, we're talking about a smaller population. We know that eating disorders, there's about 9% of the national population in the US that have an eating disorder in their lifetime. 15% of them are women. Interesting enough, though, that only 27% of people that have an eating disorder actually receive treatment. So engagement metrics are here. Again, small engagement below that 1% mark. I think it's worthy to just point out, too, obviously, that there is also a lot of members choose to go in person for care for eating disorders. It is 100% virtual. So with the member demographics, a couple things that I looked up here that I just wanted to share was that eating disorders actually prevalence does not vary amongst different demographics. The prevalence of eating disorders in patients that are Black and Hispanic, that actually therapists are less likely to recognize eating disorder symptoms, and so they just get diagnosed less. So just something, again, when I'm looking at it from kind of that equity perspective, recognizing that, something to maybe do a deeper dive in. Eating disorders do have a higher prevalence with a female population. And again, these are such small numbers of people engaging that sometimes it's also hard to kind of apply like that equity lens with small numbers. We probably have to look at all the eating disorder programs and even in network to see, what was really happening there. Questions, comments on this one? Okay, let's move to the Providence EQIP program. Similar, you can see here again, engagement and utilization on that lower level. Again, it's virtual. They were able to provide us average time to appointment is within 1 week. Our demographics, again, you can see, and those age ranges that make sense and where we see a higher prevalence of eating disorders. All right, next slide, please. Okay, Gemini. This is a program offered by MODA. This is the ones I want to say for our PEB SEOW members that does fall under the BH360 Champions program. Again, back to that goal for today of thinking about a recommendation. So Gemini is what's called a discrete video modeling program. It's digital, and it's meant to support children with autism spectrum disorder and other developmental disorders. They do have coaches available for parents. So a parent can call in and talk to a coach, ask questions. And so again, sharing here the engagement, definitely a much smaller population that would engage and benefit from these resources. You can see the members that completed an assessment. And then again, 100% text chat is the modality of those coaching sessions. And then the breakdown. And now one thing, I'm sorry, I'm looking at notes that for Gemini, there's a couple things here. So it is only, and we didn't capture this in the data that we were provided. It is only for members under the age of 18, and there are some medically necessary requirements for them to engage in this program. So just want to say the eligible numbers that are represented there are much less from the full population. It's going to be closer to that 22,000 mark just because it is for ages 18 and under. All right, and moving to the next slide then. Okay, so then the last program I think we're looking at is Hazelden, which is from MODA. So this is part of the Hazelden Betty Ford offering. I want to say with MODA, Hazelden Betty Ford is an in-network provider for substance use treatment. This is something additional that is an online resource center, has education, information, but then they also have a Hazelden Betty Ford Connections program, which is coaching and support for individuals and families. And so this is an additional offering that is only, again, available through the BH360 Champions program. So again, this is one for PEB members just to, this is part of that recommendation of adding this program from MODA. Utilization, again, you can see it's like that less than 1%. Members who completed a coaching call. So some engagement, again, there's two things offered here though. So not every member who maybe is engaging, trying to just find some resources or learn a little bit more about substance use disorder, they might not necessarily feel like they need to engage with a coach. However, it does show that people who did engage actually, are using the coaching sessions and engaging at, 8 sessions per member, and they are 100% telephonic. Interesting thing here with the demographics of providers, so 60% male, which is what we see in the prevalence of substance use disorders. We've seen a little bit of shift of this in the last couple of years for national prevalence, but still is a little bit higher prevalence with males than female. 95% urban, again, another little interesting point about that urban versus rural population. And then 76 are that ages 40 to 59. All right, I think that's the last one in our specialty program bucket. So I think before I move to the next slide, I would love if anybody has comments or your own insights. I mean, the key trends we kind of outlined at the beginning, do you see those kind of rising to the top as we did, or are there other things that stood out to you?
Mostly the trends in the demographics. I mean, I knew they were that way. I didn't realize how in some of them they were very largely that way. Right. In the behavioral health space I'm talking about.
Mm-hmm. And Bill, can I ask, like, trends in demographics, are you saying, did they surprise you or different than what you expected?
For example, the delta between female and male was larger than I expected. I expected more males to be in the category, I guess, right? Wondering about that. There is talk at a national level and behavioral and things on boys and things being falling behind in the metrics of education and career success, things like that. And I was kind of expecting to see a little more on the male side, I guess. Also, what stood out to me was the racial demographics, just the large percentage of white in those categories. Why that is? Not saying that it's only white. It was why the BIPOC people are not engaging in these things, because I think the ratio should be about the same, based on multiplied by population percentage, and I don't see that here. So that makes my head scratch a little, or gives me a head scratch. That's kind of the two demographics that stood out for me in our population, but our population is kind of skewed as well. So at least in OEB, not too badly though. I mean, right. And again, the urban rural discussion we had earlier, kind of still kind of is another puzzlement, right? Is it availability? Is it stigma? Is it what?
Mm-hmm.
Other comments from the board?
I just appreciate the in-depth look at this today. I am always trying to learn and educate myself, and there's so much I don't know. So, you know, the whole Mercer team, everybody, I mean, you know, thank you. I just, there's so much we don't know, and we just hope that we provide resources for our staff to get help. I mean, as a, you know, a very large employer, I just want my people to be okay. I can't expect them to be great, but if I can get to okay, I think some days that's a good day in corrections. So.
Yeah, the world of education right now is in a tough spot. Not just what's happening today, but you know, for the last year, 2 years, coming out of COVID, even though COVID is well behind us now in how we're adjusting and adapting, but still, the effects of COVID linger on in education for sure. I don't see anything else.
Yeah.
I mean, let's roll on.
Well, yeah, and for Kimberly too, I just want to say, the good news is too, I guess, that you all have done a good job in your recommendations and moving things forward, because oftentimes I work with lots of organizations on their behavioral health strategy, and oftentimes we find big gaps in like, oh, we're not doing this, or and I will say that while there's a lot of programs, there are not significant gaps, I think, in what you're offering. And so that's great to know that, oh, okay, we've done this exercise, and there are supports for members to engage in different ways, different modalities for different conditions, whether it's mild and moderate to severe. We do know in Oregon there's definitely a deficit in the higher acuity needs, I think, inpatient facilities and some of those things. When I read some of the Oregon news, and I know the governor is doing work on that, but that is one of the areas. And obviously that doesn't come in as much to this assessment and evaluation, but you all have done a good job of making the recommendations and asking the carriers to partner and to put solutions in place. So okay, so I'm going to move to our next. So recommended action steps. I kind of have two things here that we wanted to just pull forward. And again, this is really, I want to say, food for thought. And again, if you have, you all know your population and your members the best. And so as you digest what we went through today, I know this is a lot of information, but thinking through what are some of the opportunities that might have come up for you, or as you look at kind of some of our recommended action steps. So I'll just kind of go through these by category. So engagement and utilization, I think that was one of the most glaring areas of opportunity, I think, that engagement and utilization. So a couple things that we've kind of identified as a possible action is to continue to work on engagement efforts with carriers and the communications teams. This is ongoing. This has been going on, and I know that the staff has been working so hard on communications, and like the format of the monthly newsletters this year has really undergone a really big format change and is condition specific focused, and the wellness guides on the websites are really well designed. I know the carriers have been working as well, so this isn't to discount anything that's been done up to this point, but recognizing that this is like a process. It's a process of several years. It is also my understanding that like the website for OHA and the different benefits, right, it has to fall within a certain structure of what's allowed, and fonts and things like that. And so I know that also the OHA communication staff is working really hard at making those updates, but it is a lengthy process to do that. One of the ideas we had was working with the carriers on the use of the wellness advisor. So we know that there are, these kind of a wellness advisor, wellness programs in place where wellness advisors are engaging with either entities or agencies that are interested in some of that programming and additional support. And so is there a way to have program engagement be a key component of what those wellness advisors do? So even if they're offering some sort of education, every touch point is an opportunity to make sure that those members know about a program that ties back to that education. I'm going to go back to the wellness survey that we heard about, I think, last month at the board meetings. And, a lot of members said they didn't know about the benefits that are available to them in these areas. So one idea. Developing incremental yearly targets for engagement based on opportunity. So I'm going to show just, again, some food for thought on some engagement targets. We want to continue to monitor monitor engagement and utilization. We want to make sure if we're going to take some recommended actions, then we want to be able to measure the outcome of those actions and see if they're making an impact. And then the last one here, and I know Canopy is already, I think, working on this. So again, one that's kind of already in process. But oftentimes we see organizations that have vendor integration plans. It's something oftentimes that is verbally said, oh yes, we warm hand transfer to the medical plan, or the medical plan will warm hand transfer to the EAP, or tell people about that benefit. What we have found though is that behind the scenes, there really needs to be a process in place that the staff is trained on, that people know if a member's calling in, there's an easy access for that person, either at the carrier or the EAP or the vendor partner program, to be able to guide that member to the care that's right for them. So there's this integration amongst the benefits. And it's not like, oh, you came into point A, but point A is not right for you, and you're going to have to go back to your benefits website and find the point that's right for you. If a member entered in at point A, we want that point A person or navigation to connect them to what they need. So that's kind of what that vendor integration plan is referring to, and specifically with Canopy. Under member experience, I've kind of shared what those insights are. I think in that member experience, really having the high touch programs be the most visible. So members can do the fewest amount of clicks to find the care that they need. And then continuing to monitor that time to appointment and having expectations in place. Part of this has been done, again, with the performance guarantees and network standards project that was done through IWG. Under equity, some of the recommended actions, and again, these are some that we've talked about, is this requiring this minimum language standards of English and Spanish for all vendor partners. Working with vendors to increase that equitable access. Again, that having provider search tools should just be something that's required. Engagement, and again, calling out that engagement in rural and urban. I think we have some follow-ups to do there to really kind of peel back the layers a little bit in that to find out what's going on. And then again, continuing this ongoing monitoring of engagement in these programs and comparing that with the demographics of PEB and OEB. And then lastly, with outcomes, we could see that a lot of the programs had outcomes. So really making that be the standard. And what are the outcomes that we want? And probably getting a little bit clearer definition on exactly clinical significant outcomes for each of the vendor partner programs to make sure that they are clinically, the right outcomes to be tracking towards. And so again, just working with our carriers and vendor partners to really develop and make sure that we have similar outcome data that we're asking for, and then tracking that annually. All right, and my last slide, unfortunately, I'm apologizing ahead of time because it's a very busy slide with lots of numbers on it. So, so this was kind of, again, designed as food for thought. This is all kind of our beta of how do we approach moving this forward and using that opportunity and current engagement to be able to measure, again, a year from now, if we know that we took, these 3 recommended actions, did it make a difference? And so I'll try to walk you through just kind of what we have here is, so we have the current utilization, that's the first 2 columns in blue, and that's pulled forward from all the slides. So we have the current utilization of each of these programs. The middle white column, that's the opportunity potential. That's just showing some of that variation again, as we're talking about whether it's a broader program or maybe it's more of a clinical specialty program, that opportunity potential changes. And then the 2 columns on the right side, the 2 blue columns again, so that's kind of a recommended possible year 1 target. It's like an incremental change around 25 to 40%. I didn't mess with the ones that were less than 1%. I just kind of wanted to bump them up to 1% if they were for the full population. If they were a specialty program, then that might not be realistic. But I guess wanting feedback, thoughts on this.
And can I get like engineering nerdy wonky on you here and
please
really say that I'm not liking the opportunity potential column here at all.
Okay.
To me, the total population opportunity is 15%. So for me, and I might get this wrong, but like Kaiser has a percentage of the total population. So their target should be their percentage of the total membership times 0.15 should be the correct, and it should be a total because we don't want repetitive. We don't want people in both or all 3 things. So right. They should just have one number for all 3 in Kaiser, and the 15% should be multiplied by the percentage of the total population. So they should be around 5% total in OWEB. I'm talking about. I don't have the PEB numbers memorized. And the same thing for MODA, right? They are whatever 70%. People aren't going to. Some people will maintain like 2 or 3. They might be in Hazeldown and Maru, but most of the people are going to be in one program, so they should be 80% of 15%, and then the total of all participating in the behavioral health should be that number, not each individual program should be that number. Providence, the same thing, and realizing that Canopy is going to take market share from all 3 of the individual carrier programs, right? So those numbers are way too high, saying it just shows way too high. I mean, I understand your intent, but those numbers should be a lot lower so that the recommended year totals are going to be like the actual totals, 5%, 1%. So that's how I would do the math on that middle column. Not everybody's supposed to, it just looks like you're saying everybody goes to 15%. In reality, we want the total of all things to be around 15%. Does that make sense? Just being my engineering nerdy, and I love statistics, and that's my life. That's what I do.
I love it. It's not my life. So right. I appreciate it. I know. And I think, yes, I am tracking what you're saying. And I think, yes, I recognize that, again, people aren't going to engage in typically more than one of these programs. And so how do we capture that? And so I think that's a great takeaway for our team and our Mercer actuaries to work on.
Kind of, if I total that column, it says that every member should be participating in at least 2 programs to meet our target potential, right? That's not what you really meant, right? So
right. Yes.
Second comment I'm going to make is actually on your last slide, and I'm going to admit ignorance that something like this may actually already be happening, but I'm going to throw it down anyways. I think under engagement and utilization that people like Ali and I should present behavioral health from OWEB and PEB at, for example, the COSA conference of all building and district administration, so that as building leaders around our membership see or recognize a member in having difficulties, they know because they've seen the workshop that we present to suggest to them, hey, there's resources for you. I see you're having difficulty. I see your father died recently, and just have those hallway conversations. But we need to get it. And for OWEB, it would be, in my opinion, the COSA conference. And I'm not saying that because it's held in Seaside every year. I'm saying that because we need to get into the heads of the leadership teams of our districts and our buildings when that's where they all are at one time, right? And we present this. It'll be a very popular workshop. Everybody knows these issues. We can talk about our services, like if there's a child suicide at your school, if there's something even all the way up to a shooting, the services that we provide, just so we're in those people's heads every year, so that they know that they're pushing that down to their people as well to really get our engagement and utilization higher. Ali is still on camera, so he hasn't fallen off his chair yet, but
no, we've
I think we need to do that, and it should be at our level, where like we do it, the legislator, right, where we come in with the power voice and just say, look, here's what we really have for you, right?
That's really a great suggestion. We've actually talked at the COSA conference about wellness programs and opportunities in the past, and we have it at OASBO as well.
That's more financial, right? Building leadership is where it's at, right? Those are the people who are going to, recommend, push, engage their members, our membership into using these services, right? That's the leadership level we should be at, in my opinion, right? So, and we should do that every year, right? Just to always be there, not just when we think about it, right? We should get with the gang over there and just say, look, always have us there, right?
Sounds good.
And Bill, what you're touching on is something that is a very important component of a successful behavioral health strategy, is to have that leadership, and that having that as part of the strategy. And I know Dr. Twang talks about this often, is that that's one of those levers sometimes that it's harder for OEB and PEB to control, right? Is what's happening with leadership and how that programming and resources for employees is kind of being tracked down. I also want to say Canopy, I do believe, with PEB specifically, has done some work within the agencies on kind of what we're calling like manager training. And that's something we also are seeing, I'd say over the last 3 to 4 years, many organizations offering, is exactly what you said, equipping managers or supervisors, leadership with how to recognize an employee that might be in distress, or just not themselves, and connect them to the resources that are in the ecosystem, and again, because sometimes managers don't know how to have those conversations. They're uncomfortable with them. And they also don't want to necessarily like become that person's listening, they feel like, oh, I don't want to, I have too much on my plate already. How can I do this? And so teaching them how to listen empathetically, connect that person to the care that they need, and just feel comfortable with doing that.
And right there, you defined a better workshop, not just saying what's available, but actually talking about how to deal with behavioral health issues in your thing. That should be the workshop we present, right?
Yeah. And I think Canopy can help with that, with their hours that they have as part of their offering.
Yeah, and when I was mayor, the Public Utilities Conference in Bend every year would be another great place to hit it if I'm a PEB person, where you see, a couple thousand public service workers are there, right? PEB members are there, things like that. Anyhow, just saying. So I throw that out there just to have a point. So I made a comment on each of your slides. How about somebody else? I'm talking too much. Anybody else? I know we're all appreciative of this data. This is good input. Let's improve this. Let's make this better. Make these numbers better. Glenn.
No, I just want to share my appreciation and Margaret can chime in too, is as the staff people who have worked consistently with the wellness programs and also being with SEOW, that this really detailed but presentation that they provided, but also getting into the issue of setting targets really is extremely helpful, especially for a group like SEOW when looking at these programs to be able to say, are they being successful? And that's where I think the really the targets comes in, because it really does help, in evaluating the programs.
Okay, we're closing in on noon. Let me just do a quick ask of Rose. Any public comment?
No public comment.
All righty. All right, this was a deep meeting. I thought, even though it was just two items on the agenda, there was a lot that we just rolled through. It's really cool for me, even though it's it's taken a while from my participation here, to see the PEB and OWEB stuff done side by side. I'm really happy we made this change on SEOW, that we're getting to see both halves of the equation. Yeah, I'm only interested in what I'm doing with OWEB, but it's very interesting to see the PEB stuff and get that frame and get that reference point in my mind to understand that. And so that is excellent. And I really like the way we're doing SEOW now. Just saying, that's my point of view. Great. Okay, I don't see any hands up. I will say for the OWEB people, you got 1 hour for lunch. Oh, Greg, you got your hand up? Oh.
I would just like to say, sitting in these meetings and trying to put in my mind what we do in PEB and listening to what OWEB has been doing for about a year, it is also very nice now to be able to vote. As well as have a voice. And it was always a voice, but it was always, what do you think, not as a board member.
Yeah.
So it's kind of nice going forward to have both sitting and being able to say, this is what we're doing, this is what we're doing, this is what has worked for us, and this is what not has worked for us. So much better. Thank you.
Excellent. All right, OWEB members, see you in an hour. PEB members, have a nice day. Bye-bye. Meeting is adjourned.